It's with joy that I'm get to introduce Dr. Engwall. I have never met him before, and so I'm looking forward to this conversation, but have heard wonderful things. He has a plethora of experience gained over the past 25 years as a child, adolescent, and adult psychiatrist. He's physically in Berkeley, California, doing private practice, but has received a lot of different trainings throughout the country. He trained at the University of Chicago for his MD, residency in the University of California, San Francisco, and then stayed there for child and adolescent training. Um, He's also studied a great deal on EEG and neurofeedback that he's going to share with us, and has nationally renowned mentors in the field. Also has done certification in TMS and non-invasive neurostimulation through the Berenson Allen Center for Non-Invasive Brain Stimulation at Harvard Medical School. In his practice, he uses neurofeedback, also non invasive neuromodulation approaches, including photobiomodulation, transcranial electrical stimulation, and transcranial vagus nerve stimulation. So I know this is we might have time to hear about all of those things, but it's a delight to hear about all his knowledge base includes. And also, with all of that, also stays grounded in experiential and existential psychotherapy. He's been honored to be named as a fellow of the American Psychiatric Association and to receive the Daniel X. Friedman Award for Excellence in Psychiatry and the ACAP Outstanding Fellow in Child and Adolescent Psychiatry Award. He serves as volunteer faculty at UCSF, where he enjoys working with fellows or child and adolescent psychiatry fellows. And he reached out with the offering to share his knowledge with us, and we're very excited to have him here.
Thanks for having me. I'm excited to be here. And I don't know about you guys, but integrative medicine for me um, is just good medicine.
Mm, very true.
Integrating lifestyle practices and, you know, skillful means as they may come available. And so I had my eye on neurofeedback as a potentially evidence-based intervention that would offer a non-medication alternative and a non-therapy alternative for those who don't find that a congenial way of approaching their mental health. I to directly impact symptoms from a physiological point of view. So, uh, that's how I got interested. And I had mentors that kind of took me along the way. And the evidence was iffy when I started out. But this is the kind of neurofeedback, the precision form neurofeedback that really caught my interest. So I'm really excited to share it with you guys and hear any questions you have about how we can apply it. So I'm going to just share with you to start out that, oopsie, somehow things are not working normally. Okay, now they are. I have no conflicts of interest. I don't have any investments or um, interest in any of the companies or products I'll discuss. However, I guess I do have a practice that offers neurofeedback, so that hopefully is clear. So I want to start off by just noting that we have gained a lot of knowledge in the last 30 years, but we haven't really applied a lot of the knowledge we've gained through the Human Connectome Project and the European Brain Project to uh, to the clinic and brought it to our patients. So why aren't we doing that? And I'll just say that precision neurofeedback harnesses a lot of this information. The Human Connectome Project was helped us understand neural networks and a lot more about which networks related to different symptoms and symptom pictures. So that's a lot about what we'll be doing, especially in the context where we've of a lot of the failure of the psychopharmacology project that began in the 70s, not only do 40 to 60% of folks wind up non-responders to psychopharmacology, we we experience, these are tested for single diagnoses, and I don't know how many of you treat patients with single DSM diagnoses, but that's not the norm. Comorbidity is the norm. And um, so in a pharmacology-based practice, we wind up giving people not just one or two or three, oftentimes it's numerous medications if that's what we have at our disposal. So how about affecting the physiology using the newer information we have through a non-medication alternative? Does that work, and how can we do that? So neurofeedback kind of was asking that question a long time ago, back in the 60s, and it has evolved. So I'm just going to demystify a little bit what neurofeedback is at the beginning. How many of you guys know about neurofeedback, know how it works? Okay, so it's essentially based on operant conditioning of the EEG. So we measure the EEG while somebody is interacting with, say, video content or waiting for auditory rewards. And um, when the computer sees that, uh, the brain state is approaching uh, the goals that we've set that are presumably a healthier brain state. So when the brain state approaches that healthier brain state that we're targeting, it gives a reward to the patient uh, through the video aspect of what they're interacting with or auditory. Uh, and that can be progress in a game, or it can be the change in the size of the screen. Um, and as the brain learns to regulate states better over time, uh, it begins to be able to self-regulate into those positive states of mind more efficiently and more regularly. So I'm going to talk a little bit about the evolution of neurofeedback from just measuring uh, the electrical activity of the cortex and using that to make assumptions about what's right and what's a good direction to train, what's a bad direction to train. And we know that like ADHD, it has a common neural signature of slowness in the prefrontal cortex, and we could kind of try to diminish that slowness as a traditional neurofeedback technique, just having a single electrode where we try to diminish the slow waves uh, and reward that. Uh, so that was the old form. Uh, and then we found that we could get a database of people who didn't have neuropsychiatric illness and compare our patients' brain waves with uh, the database and see how normal or abnormal those were. And we called that Z-score because we'd use standard deviations from the mean for that person's age uh, to score what was normal and abnormal. Uh, and that evolved then to taking from a two-dimensional view of what was abnormal or normal to a three-dimensional view when we got more complex mathematics involved. And so now we are able to, with Loretta, particularly SW Loretta, which is a weighted form of the Loretta algorithm, we're able to resolve up to 12,000 different areas of the brain, and both information flow between these different areas as well as activity in those areas. So we're able to resolve the activity and the interplay, say, between the amygdala and different Brodmann areas, say in the prefrontal cortex, or even in the cerebellum. So by seeing this, we can understand with a database to see what's normal in terms of information flow and activity and what's abnormal. We're able to tell where brain networks are functioning well and where they're having problems. And if we can help people regulate their brain networks to be within normal functioning, we can decrease symptoms. That's the hope. So that's the premise. Uh, so before we can train them, we have to understand what is, showing up in their brain. And so we measure functional connectivity in terms of ability to synchronize between different areas of the brain. And these might be slow, or they might be fast if they're red, or phase lag, which is timing, how quickly or um, deeply do areas process information and sharing information with each other. Is it a very slow process or is it very quick? Um, so basically, it uses all 19 channels. You have to have a full EEG cap to do this kind of training. You compare that activity to age-matched controls, and this can be applied to different networks in the brain that relate to ADHD, anxiety, depression, PTSD, and persistent symptoms of TBI and autism in a number of different applications. Um, so it's kind of like the old, this has a lot of information, bear with me. We're going to just take the last point here. I like to use the analogy of the brain as a symphony, and each network has to interplay, has a nuanced interplay, just like sections of an orchestra have timing, tempo, voicing, that have to be coordinated in a particular way in order for the music to sound appropriate, right? So the old form of looking at EEGs and doing neurofeedback back in the 70s was like listening to a mono stereo recording where you really couldn't hear where the string section was and where the drums were, um, versus being the conductor of an orchestra, standing in the middle of all the orchestra and being able to hear and see the nuanced interplay. And neurofeedback helps uh, helps you direct areas of the brain or the orchestra of the brain to create this beautiful music. So that's really where we're headed. And uh, this is the idea is, of course, that symptoms are not beautiful music, not really what we're hoping for out of, say, the dorsal attention network or the reward network or the depression related areas. If they're not coordinating together well, we get symptoms. So the hope is to shift those symptoms by training those connections in the networks. These are typical networks that will train. The default mode network is kind of what connects in the brain when you're not doing a task. It's the default mode. The salience network, which tells you to pay attention to something or what to pay attention to. Dorsal attention network, the reward network. And these are all related to different DSM diagnoses. And so the idea is to look at the non-normative connections, the areas with poor functional connectivity. And you look at what these networks, mostly they're functioning pretty well, even if they're causing symptoms. 90%, if not more, of these networks are functioning within normal limits. It's just a few bad links, maybe less than 10%, that need to be trained. So, and so that's why I think of this as unlocking potential, because you really have most everything functioning fine. Um, and I think patients get a different view of themselves, that they think they're total failures when really it's amazing everything is working as well as it does. And there are a few weak links that need to be strengthened, and things do a lot better. So, I of course, people have been interested in seeing whether this really is effective, testing this hypothesis of functional connectivity training. Um, so using precision neurofeedback uh, uh, techniques and technology uh, to do neurofeedback on different populations, we've developed a decent evidence base here, stronger than for standard or traditional neurofeedback. Uh, I'd say substantially stronger at this point, and really only in the last few years. This hasn't been out there for very long. SW neurofeedback just was out 7 years ago, so we're just getting findings now in the last couple of years. So there was a study done in Canada on anxious depression where they found that 10 sessions of precision neurofeedback reduced depression anxiety symptoms significantly versus a control group that was a waiting group. Uh, Study in PTSD, also controlled uh, and randomized, showed significant improvement in PTSD symptoms in 15 sessions. Uh, Samadhi and last year published this really interesting study that compared precision neurofeedback of ADHD to traditional neurofeedback and a waitlist group. So 20 participants ages 7 to 12 in each group, and precision neurofeedback and traditional neurofeedback outperformed the control group at uh, at a significance level of 0.05, and then precision neurofeedback was superior to traditional neurofeedback at a level of 0.01. So highly significant differences. It's also used for post-concussive syndrome, and I'll get to that in a minute. Uh, there was a really interesting study done by Basiri published in 2024, uh, comparing precision neurofeedback to CBT for insomnia for patients with insomnia, um, and found that the neurofeedback, 10 sessions of neurofeedback, was superior to CBT for insomnia in terms of their insomnia complaints. Uh, they were close, and I have to say that this slide got it worded slightly wrong. That while the improvement was superior numerically to the CBT for insomnia group, they were comparable. There wasn't a significant difference. So there was a numerical superiority, but that could have been by chance. They were essentially equivalent. But to have 10 sessions, if somebody fails CBT for insomnia, this is a nice alternative, and they might work nicely synergistically because on one level, you're changing the networks that are keeping people hyper aroused. And on another level, you're changing their relationship to sleep with CBT for insomnia. So, you're changing things on the software end and the hardware end. And so it might be nice, might be a nice synergism. I'd be interested in seeing the combined effect. Um, but I think practically that's kind of how I would approach it. The CBT for insomnia is such a low risk, low um, cost intervention. And then in 2024, this was news to me. There's a company that produced a device called Prism that was cleared by the FDA for PTSD that uses precision neurofeedback, SW Loretta um, training. So let's see, uh, just so people understand the course of this sort of neurofeedback, we do an assessment, we get the analysis to look for the weak links in related um, brain networks. Uh, and if we can relate the symptoms to brain network dysfunction or dysregulation, then we pick those areas of dysregulation to train, And then we move on to do about 10 neurofeedback sessions usually. Uh, and if those go well, if they seem to proceed well, uh, we will then do another EEG to see how we've progressed and to pick the next areas of dysfunction or dysregulation in networks that we want to target. And most symptoms will need like 3 rounds of this to be trained if you're training one symptom domain, such as attention. I want to present a case of this just so people understand. Um, Excuse me, can you tell me, Amelia, when did I start?
About 12:20. And usually we just like to leave 5 to 10 minutes for questions.
Okay, so how many more minutes do I have?
About 10, if that's
Okay, 10
okay.
more
Is that
minutes.
enough?
We're great.
Okay.
Great. So let me just share this case with you. His name is HL. He was referred to me for ADHD, but he also had THC use and symptoms of depression. And it really was more of an adjustment disorder with depression. He had been diagnosed prior to this presentation with neuropsych testing that revealed inattentive picture of ADHD. Uh, but he came in uh, after his grades started dropping. Uh, he started losing motivation to do things. He'd sit around and just watch Family Guy. Mom couldn't get him to do anything else. He lost interest in prior hobbies, wasn't as interested in lacrosse as normal, became uh, kind of hopeless, although not he wouldn't talk about it. But when you asked him, he really wasn't very hopeful about his future. He didn't have a lot of future orientation, and self-esteem was low. Um, and this was related. This kind of led to more cannabis use. He had used it socially before, but it became more regular. Um, and this happened. This kind of onset happened throughout the fall, which is notable because he did play lacrosse. He was passionate about lacrosse, even though his passion waned over the through the season. Uh, but these symptoms were worsening during his lacrosse season, and I'm telling this story as if it's an ADHD story, and at the time I thought it was an ADHD and substance use problem and possibly a mood problem. But in retrospect, this was actually a concussion problem. This is ADHD, depression symptoms uh, linked to lingering post-concussive injuries. He denied concussion history at the outset um, and initially refused any help of any sort. I offered neurofeedback because the parents and he were more interested in non-medication interventions, but I also offered SSRIs. I also offered psychotherapy, and that was not, neither one was a starter for him. So eventually, his parents decided this is getting close to going off to college. We really want you to start doing something about, you know, your ADHD, and you're not doing well in school. We'll pay you to do neurofeedback. So he got $50 a session for attending neurofeedback. That was worth it to him. After a while, he started being more engaged with it and didn't need to be paid to come. But in the beginning, that's what got him in. And we found initially that the reward slash addiction network, it's it's combined in the software that I use because they overlap so much. That was the most dysregulated network. So we started with that, but we also trained a number of other networks, the salience, dorsal attention, ventral attention, default mode, and depression related networks for a total of 40 sessions. He had each protocol was trained really well. He did a great job with the training. And I'll show you the training here. So this is a pre and post picture of, I'm going to show you 4 slides with different um, different pictures of pre and post training. And this was in delta. Delta are slow brain waves. Uh, Alpha, theta is slow. I'm not going to really show you theta because that wasn't a big issue for him. Alpha is the next highest in frequency. Then it gets into what's called beta. Um, so this is what his brain looked like in terms of these lines represent uh, areas that are not connecting, and we're looking just at coherence or synchronization. They're not able to share information directly or reach each other very well. These are outside of 1.65 standard deviations from the norm for his age. And you can see that it looks like this is kind of like a starburst pattern from the frontal lobes back through the brain, which should have been my first clue. And this is a sort of connectome view. And we can see the front of the brain here extending on through the back. And this is a lot of cerebellum back here as well as visual cortex. Uh, so we can see it's kind of uh, right-sided focused disconnections. Uh, so after he was completely done with the 40 sessions of training, this is what delta looked like, looking for abnormal connections. There were a few. So he did really well. Um, I don't know if this makes sense, but the orange lines represent hyper connections or functioning of one area that hijacks the other. And the blue lines represent areas that don't coordinate with each other. So we're just going to look at coherence here. We could look at phase, but coherence was most illustrative of his symptoms. We did train phase, and there were certainly differences or issues there. Let's see. And I'll share with you some of the phase data too. But this is pre-training in alpha. Look at that. It's almost like every area is disconnected and significantly so. And again, it's a little right-sided focus. You can see more of the dark red. That's more significant. The farther the greater the significance, the darker the color, or the further out on the red. And same with the blue. The darker the blue for hypercoherent. Um, so I you can see the dramatic difference, and these differences corresponded with an excellent outcome. So this is high beta. And then I'm going to show you another way of viewing this data. The left side of the screen is pre-training, the right side is post-training. So this shows you kind of in the green, these are the Brodmann area or the deep structure labeled connections that are being looked at. And you can see standard deviations from the norm here. So this looks at delta, theta, alpha, and faster brainwaves. So it's from left to right, faster uh, brainwaves. And how normative or non-normative those connections are. So we picked these to train. This is just half of the protocol. And you can see how well it was trained post. So really excellent training for a lot, really significant disconnectivity. 4 and 5 standard deviations is severe. This is phase. This is another way of we can look at it three-dimensionally, but really we make selections here because we can make them in a more nuanced way, seeing the numbers. And again, I don't know if you can see, but area 11 on the left and the amygdala on the left is showing up. And then area 11, which is the Brodmann area 11 is supraorbital. So it's in the orbital frontal cortex, but just above the orbits, and is involved with personality or emotional expression, but also in directing attention. So um, that that was one of the most disconnected areas in phase and in coherence. But this is just to illustrate the quality of the training. And then just a little follow up. I just spoke to his mother yesterday. I speak to her about once a year. Uh, he went off to, well, before he went off to college, his parents thought he needed accommodation still for ADHD. But when they went to test, he had had neuropsych testing before, so he, his neuropsychologist did another round of testing and found no evidence to support he had ADHD any longer or a need for any accommodations. So this was the only intervention that occurred. So a substantial improvement in his functioning. ADHD, executive functioning wise, mood wise. Uh, so he went off to the University of Utah, did well there, and then transferred after a year so he could be, since his grades were good enough there, they accepted him as a transfer student at University of Washington, where his girlfriend was, uh, longstanding girlfriend from high school. And this spring, he is graduating with a double major, has a 3.9 GPA, and just received a new, kind of choke up when I see this, a near perfect score on his LSAT. So, as I say, like looking back on this hypocoherence in this particular pattern uh, in delta and alpha is what we see. And I've learned over the years since I treated him, I've learned more about what we see in post TBI. It is what we see in TBI. And it's not surprising because he was a very intense and, you know, very, yeah, he was very intense in the way he played lacrosse. And though he didn't, I don't think people were really looking at concussions as carefully back in 2000 as they are now in high school sports. And even now, we really can't see the invisible persisting injuries. They don't show up on MRI. They, they do show up on diffusion tensor imaging, but that is rare. It's hard to refer. You probably have it at University of Arizona. They have it at UCSF. It's hard to get. Uh, but we can see it from an EEG. We can see the disconnectivity and we can retrain it. So people who it may be, it would decrease the potential of people winding up with CTE and the severe neuropsychiatric complexities that those folks run into. But at least it would help us understand when people could return to playing, because kids are returned to play far too early with persistent injury that is not picked up by the current standards. So anyway, that is something I'm really fascinated with. So you might wonder if there are any problems with when side effects that might occur when you refer somebody for neurofeedback training. There are some minor problems. It's generally well tolerated, uh, but it's still work for the brain. If you're subject to migraines, it can trigger migraines, but it also can treat migraines. So it's not one or the other. We usually just have to adjust we have to adjust the training to either make it a shorter training or a less intensive training, adding more breaks possibly, uh, you know, and that'll mitigate from, the problems for 99% of folks. Uh, some people just don't tolerate having a cap on their head, and for those people, it's very difficult to endure uh, if they're, say, highly sensitive in that regard. Um, and then another thing just to mention is that neurofeedback is not well regulated. There are two professional bodies that compete, and none of them there are no state bodies that regulate this. So it you can put up a plaque and say you're offering neurofeedback with a high school diploma, or not even, you know. So just be aware that it's not regulated. Make sure that whoever you're referring to has an appropriate kind of training and background in understanding neurophysiology and EEG, because a lot of neurofeedback training is that's done out there is done without even looking at the EEG. You come in, you say you have a symptom, and they say, "Oh, we'll just put an electrode here, and we'll down train this, and we'll up train that." And you know, I don't think that's good quality care. Um, so let's see. So just to summarize, precision EEG tools offer help with assessment. They can help us understand network disconnectivity and connectivity, dysregulation in areas in cortical areas and deep structures. It's helpful for case formulation, helpful for seeing TBI injury, helpful for predicting medication herb response and side effects from medications. Um, and of course, for creating neurofeedback protocols in those dysregulated networks. Uh, with neurofeedback, we can address uh, cognitive domains, affective domains, and pain. Um, Autism is an area that I've become really passionate about because there's so little that can be done for a lot of the neurodiversity that they experience, and it is such a neurodiverse um, diagnosis. Shows up in so many different ways, uh, and this type of assessment and training can see where the dysregulation is and train that dysregulation. So I've had a lot of autism patients get significant benefit. Uh, and the only people who really can't train well are people with schizophrenia or degenerative conditions such as, dementias. So uh, there, there's some hope for Parkinson's, but I don't really believe that that's going to it really addresses more like symptoms that are not the main Parkinsonian tremor, but more, we might be able to treat that, but I don't see that right now. More we're able to address depression that might come along with Parkinson's and other mental health problems that may come along with it. So
Well,
with
this
that,
certainly has. Sorry, please.
yeah, with that, I just really want to thank you guys for your attention and for the invitation to be here.